Good evening, everyone, and very, very happy spring season to everyone. I think it's time that we are able to enjoy a bit of spring this year. The COVID is trying to go away, and we are all trying to move out. But yes, everybody is very comfortable, doing these meetings from home because it is saving a lot of traveling time. So I suppose this transition, which has started in COVID, a good thing, will go on. And this last month has been, full of activities from Foxy because of the Foxy election. So all the Foxy people are wanting to do activities and wanting to do it with Delhi being the biggest society. So we've had a lot of activities with Foxy and our own activities also. And I think this March is going to be like that. But I think everybody must vote. Whosoever you think is the right candidate, you must vote. You should not let your, vote go waste. I mean, what you do is important. Each vote counts. So with that note, I request Monica to give the minutes of the last meeting. And after that, I will hand over to Amita for the proceeding of the monthly meeting at GTB. Monica.
Thank you, ma'am. I'll just share my screen. Screen visible? Minutes delay. So I'm giving the secretary report for the month of February. We'll start with the AOGD monthly clinical meeting, which was held in Ram Manohar Lohia Hospital on 28th of January. Interesting cases were discussed in this meeting, which was followed by AOGD CME on research methodology, which was well attended by many postgraduates on 31st January. Then there was this AOGD CME on hypertensive disorders of pregnancy on 18th of February. Then we did a training program in collaboration with Foxy and WHO on respectful abortion care on 19th February. This is a Foxy nationwide program, and a few master trainers have been trained for this program, which will be conducting the programs to train all the AOGD members. Then there was this CME on salvaging tubes medically and surgically, which was done in association with the DGF Southwest on 8th of February. Coming to subcommittee programs, adolescent subcommittee did two programs in February. One was optimizing nutrition and mental health of adolescent on 3rd February, and another was online adolescent health problems counseling discussion on 13th February. Multidisciplinary subcommittee did two programs again. First was a multidisciplinary approach to breast lump and fertility preservation in breast cancer on 5th February. Then they did a hands-on PPH workshop at SGT Medical College and Hospital in Gurugram on 18th February. AOGD Infertility Subcommittee did two programs. One was a CME on infertility in association with Indian Medical Association South Delhi branch on 12th February. Then they did a physical CME also on infertility in association with IMA South Delhi. Apologies for the date, this is 19th February. Then AOGD Safe Motherhood Subcommittee did the program on delving into clinical concerns of intrahepatic cholestasis of pregnancy on 19th February. This was a very interesting program, and we had an international speaker, Professor Catherine Williamson from King's College London. Then our, AOGD Quality Improvement Subcommittee did a program on optimizing the pregnancy outcomes in thalassaemic women in association with DGF on 22nd February. Then there was this masterclass on vaginoplasty to reconstruction to rejuvenation by AOGD Endoscopy Subcommittee, which was just yesterday. Regarding the PG forum classes, this time we had a class on recurrent pregnancy loss on 21st February. And now comes the interesting declaration for the forthcoming elected president and vice president. So congratulations, Dr. Asmita Rathore, for being elected as AOGD president, and Dr. Vayamala as AOGD vice president for the year 2022-23. As regards the subcommittee chairperson elections for the tenure from 2022-24, for the breast and cervical cancer awareness screening and prevention subcommittee, Dr. Mrinalini Mani has been elected. She's from Guru Gobind Singh Hospital. For infertility subcommittee, the incoming chairperson would be Dr. Manju Khivani from Max Smart Super Speciality Hospital. For rural health subcommittee, Dr. Shivani Agrawal has been elected. She's from Kasturba Hospital. And for multidisciplinary committee, Dr. Kiran Guleria from UCMS and GTB Hospital. Congratulations to all. As regards the forthcoming events, we would be having a program on breast and ovarian cancer by oncology subcommittee on 26 February, a CME on PPH by multidisciplinary subcommittee, AOGD CME on eye care for contraception with Foxy Family Welfare Subcommittee, Family Welfare Committee on 1st March. Then AOGD Public Forum on Polycystic Ovary on 1st March, CME on Anorectal Physiology for Gynecologists by Urogynecology Subcommittee on 5th March, Women's Day celebration by AOGD and BGF on 8th March, case-based discussion in fetal medicine by Fetal Medicine and Genetics Subcommittee on 10th March. Then we have an AOGD CME on thyroid disorders on 15th March, another CME program yet to be disclosed by Oncology Subcommittee on 19th March. PG Forum class this time would be on endometriosis on 21st March. CME on PCOS by Foxy Endocrinology Subcommittee Association with the AOGD on 23rd March. Endoscopy Subcommittee will be conducting a program on 24th March, and Cancer Endometrium Less is More program by Oncology Subcommittee on 26th March. And lastly, we have an AOGD CME on feto-maternal infections, prevention and care with the Society for Fetal Medicine Delhi chapter on 31st March. Then comes the all-important announcement of the next monthly and the last in our tenure would be the monthly clinical meeting to be held at Safdarjung Hospital on 25th March. And this will be accompanied with the handover ceremony of the Secretariat. And of course, there will be one GBM which will be held with the next AOGD clinical meeting. Dr. Achla, would you like to elaborate on the GBM?
Yeah, actually, with the every time when we do the handing over, there is a GBM in which we will be also just giving our, account statement and whatever we've done, plus whatever decisions were taken in the last executive meeting, they have not still gone to GBM, so those also have to go. So whatever way we do it, probably it will be virtual only because people don't seem to be in a mood to be coming physical. So we'll do it hybrid. Anybody who wants to come can come. Others will be able to join. So it has been a very, very nice year working with everyone. So all good things must come to an end and better things to start. Yeah. So over to you, Amita, for the monthly meeting.
You are muted, Amita.
Thank you for correcting me. So very good evening, and thank you, Monica and Dr. Achla. And I was saying that it was a very wonderful, fruitful year, and you have done a lot for AOGD, and we all have enjoyed the academics and your active, wonderful performance. So, dear President AOGD, Dr. Achla, team AOGD, senior members, and honorable judges, and dear friends. It's my pleasing duty to welcome you all for the AOGD Clinical Monthly Meeting, which is to be hosted by Department of Obs-Gynae of UCMS GTB Hospital. Today we have 3 interesting, unique clinical cases, one from each unit with successful management. And at the end, Dr. Radhika will throw some light on Chaya. And as the protocol is, I think questions will be asked by the judges at at the end of the presentations. And it's my request to the members, whoever wants to ask the question, put it in the chat box. And so I will request now Dr. Suman, Senior Resident, and Dr. Vindya, Associate Professor in the department, to present the first case. And it is about a case of carcinoma cervix with a lot of complexities. And this patient was referred to us after simple hysterectomy done for AOGD. So over to Dr. Suman, please.
Good afternoon, respected seniors and dear friends. I am presenting case of cervical cancer with complex presentation and their definite solutions. Mrs. X, 51-year-old lady, para 3 live 3, referred to gynae OPD from Delhi State Cancer Institute in September 2021. She presented with complaints of continuous dribbling of urine since 1 year 9 months and lump in left lower abdomen since 1 year. She had undergone total abdominal hysterectomy at private hospital in Rampur, UP 1 year 9 months ago in view of postcoital bleeding and discharge per vagina. On post-operative day 2, she started continuous dribbling of urine after Foley's catheter removal, for which she was recatheterized for 3 months. Still, patient was incontinent. Histopathology report revealed it was moderately differentiated squamous cell cancer cervix with at least stage 1B3. Depth and margins could not be commented as specimen was sent in piecemeal with largest size of tumor around 6 cm with uterine involvement. Then she referred to Cancer Institute where histopathology slides were reviewed which showed a squamous cell cancer cervix. 2 months post-surgery, PET-CT was done which showed a FDG avid infiltrating nodular lesion in the vaginal wall with left parametrial involvement and uptake in upper 2/3 of vagina, left adnexa and inferior part of left rectus abdominis muscle. And there was hypermetabolic goiter, for which she received complete concurrent chemoradiation and completed in August 2020. After that, she started feeling a lump in left lower abdomen near scar, for which PET-CT was done, which showed a uptake in soft tissue lesion on the left side of anterior abdominal wall and at the vault. For that, USG-guided FNAC was done, which showed a deposits of squamous cell carcinoma, for which she received 7 cycles of 4-drug regime chemotherapy over a period of 6 months, completed in June 2021. Then she referred to gynae department for VVF repair and subcutaneous nodule excision as nodule was not responded to chemotherapy. On examination, her ECOG performance score was good, vitals were stable, thyroid was enlarged with firm nodule on left side, bilateral breasts were normal, her chest and cardiovascular examination was normal. On per abdominal examination, a well-defined lump of 3 into 2.5 cm felt on left side of transverse scar, which was hard, non-tender with restricted mobility. On local examination, dribbling of urine with excoriation marks at vulva was noted. On per speculum examination, vagina was atrophy post-radiotherapy. Vault was healthy. A single fistula of 0.5 into 0.5 cm was seen at left angle of vault. Same fistula was felt on a per vaginal examination and no growth was found. On per rectal examination, there was an induration on left side of vault. Our provisional diagnosis at admission, 51-year-old lady, para 3 live 3 with squamous cell cancer cervix with post total abdominal hysterectomy, post concurrent chemoradiation and chemotherapy with vesicovaginal fistula with metastatic cutaneous nodule and thyroid swelling. Her routine investigations were normal except mild anemia. For thyroid evaluation, ultrasound guided FNAC of thyroid nodule was done, which showed a papillary carcinoma of thyroid and indirect laryngoscopy was normal. To look for distant metastasis, PET-CT was done, which showed a uptake in the soft tissue lesion in the left anterior abdominal wall and uptake at the vaginal wall. And there was also uptake on the left lobe of a thyroid gland. However, no other evidence of metabolic active disease elsewhere in the body. Further, to better delineate soft tissue invasion, contrast enhanced MRI pelvis was done, which showed a nodular lesion at the post-operative stump without parametrial involvement, and another lobulated lesion on the left side of lower anterior abdominal wall, which were indenting the overlying muscle but not involving it. Then examination and cystoscopy was done in OT, and a supratrigonal fistula of 1.5 into 1 cm was visualized just lateral to fundus of bladder on a left side, 1 cm away from left ureter. Bilateral ureteric reflux was seen and normal. Vagina was narrow and atrophic post radiotherapy and no growth felt at vault. Then case was discussed in tumor board and a joint decision was taken to do a salvage surgery with excision of vault growth and subcutaneous nodule with VVF repair, followed by thyroid surgery in second sitting. After extensive patient counseling and detailed informed consent, she underwent salvage surgery with bilateral salpingo-oophorectomy with vault biopsy with transvesical VVF repair with subcutaneous metastatic nodule excision. Intraoperatively, bilateral tubes and ovaries were buried in dense adhesion at vault. Vault was opened, no growth found, vault biopsies were taken. Transvesical supratrigonal fistula was repaired without omental graft as bladder was well vascularized and tissues were pliable. In the end, subcutaneous metastatic nodule was excised to prevent spillage of tumor. Primary closure was done as no muscle involvement. Her immediate post-op period was uneventful. She received thromboprophylaxis. After catheter removal, patient was continent in her immediate post-op period. On final histopathology report, subcutaneous nodule was positive for squamous cell cancer and left ovary was positive for metastasis from squamous cell cancer. Right ovary showed fibrosis with foci of calcification and vault biopsy was negative for malignancy. Now Dr. Bindya Gupta will continue with the discussion part.
So thank you so much, Suman. So the issues to address in this case was that this lady was incomplete surgery done for cancer cervix, post chemo radiation and chemotherapy. She had cutaneous metastasis. There was ovarian metastasis. There was associated thyroid malignancy. And we did surgery in an irradiated abdomen. So how complex this can be. And also attempted a VVF repair. So this patient was an inadvertent diagnosis of invasive cancer after a hysterectomy. Now she received complete chemo radiation and chemotherapy. However, this situation could have easily been avoided if the initial assessment done by the operating surgeon was adequate and adequate treatment would have been given to her at that particular time. However, the situation was not right. The patient had presented with skin metastasis. This is a rare presentation. Only 80 cases have been reported in literature. The most common sites are the lower abdominal wall, the vulva, the anterior chest wall, and they normally present as nodules, plaques, or inflammatory telangiectatic lesions. The mechanism is a retrograde dissemination of the tumor, secondary to lymphatic obstruction. And since it's a rare presentation, so no standard treatment is there. Either we can use a combination or alone, radiotherapy, chemotherapy, or a wide local excision. But skin metastasis may be considered as a pre-terminal sign. The mean survival is just 3 months, and only 20% of the women, they survive up to 1 year. Now, in the present case, this nodule was present in the lower abdomen, just adjacent to the incision site. And on MRI, the lesion was not involving the muscles, but indenting it. So could this be just an implantation of the tumor deposit, since it was a piecemeal extraction of the tumor during the specimen retrieval? And we did a complete excision of the tumor without excising the muscle. Now, this lady also had ovarian metastasis, again, a rare presentation in cervical cancer. It is much rarer in squamous cell cancers compared to cervical adenocarcinomas. Ovarian metastases are usually microscopic, unilateral, and confined to ovarian parenchyma. And again, the route of spread is predominantly lymphatic, but they can be transtubal implantation if suppose the uterine corpus is involved, as it was also there in the present case. In a systematic review, they showed that what are the attributable risk factors for ovarian metastasis, and the factors which were there were histological type, adenocarcinomas, more than squamous cell cancer, if age is more than 40 years, if the tumor is bulky, if there's pelvic lymph node involvement, if there's lymphovascular space invasion, parametrial invasion, or corpus uteri involvement. In the revised FIGO 2018 classification, it is unclear how to stage ovarian metastasis. For instance, if a patient has a 1B1 tumor, like 2 centimeters, with negative lymph nodes, negative parametria, but evidence of microscopic disease in the ovary, should we assign it to FIGO stage 4A? Because 4A is basically when the disease is extended beyond the true pelvis. So this is still very unclear how to keep ovarian metastasis according to the FIGO staging. But definitely, ovarian metastasis is associated with reduced survival. In a very elegant review, Shimada et al. In 2006 compared the ovarian survival 5-year OS with overall 5-year OS survival according to the FIGO staging. So in 1B1 and 2A, the survival was almost reduced by 50% if there was presence of ovarian metastasis. And in stage 2B, the 5-year OS was 73%. However, in the presence of ovarian metastasis, it reduced dramatically to just 18%. So definitely ovarian metastasis is a sign of poor prognosis. Another challenge we had in this patient was repair of VVF in an irradiated abdomen. In a systematic review by Toya et al., they analyzed their own cases of fistula repair after gynecological surgery who have undergone radiotherapy. They found that if the fistula repair was caused by surgical trauma and radiotherapy was just an incidental finding, 100% success of fistula repair is there compared to fistulas which arise as a result of radiation-induced necrosis. It is around 40%. However, challenges like pelvic fibrosis, ischemia, poor bladder viability, compromised bladder function, and ureteric involvement are there in both the situations. Now, in our patient, we took a abdominal route because we did not prefer LATSCO because the vagina was already constricted following the brachytherapy. And since the bladder was well vascularized and pliable, we did not have to use any grafts. However, surgeons have used omental grafts during the fistula repair for better vascularization. Now, this patient also had an associated papillary thyroid cancer. However, this is a moderate, well-differentiated malignancy, and normally distant metastases are rare, a slow-growing tumor, and that's why we decided during the tumor board that we can take this aspect in the secondary sitting after dealing with the primary malignancy. So on follow-up, after 6 months, the patient has completed 5 cycles of chemotherapy, and the last chemotherapy was given in February 2022. And she's been planned for a repeat PET-CT after 4 weeks, and then followed by that, once it is negative, we'll be taking her up for thyroid surgery after the PET-CT report. So dealing with this complex maze of problems, we did definitely arrive at a specific situation. We gave a good solution to the patient because, we practiced all the following aspects. We individualized the management. We dealt with all the complexities one by one and offered certain definite solutions to those complexities. We had a shared decision-making by the multidisciplinary tumor board. The thorough patient counseling was done and informed consent was taken. And long-term prognosis, however, is uncertain because we do not know what's going to happen. But yes, we did offer an improvement in quality of life for the patient. Hence, salvage surgery should be offered, especially in the setting where we can improve the quality of life of the patient, because whatever years of life she has, there should be enough life in them. And most important message that we want to share is that this is an entirely preventable solution. Had the initial assessment been done properly, these disastrous consequences would never have happened. Thank you very much.
Thank you, Suman and Bindya, for the good presentation. And we come to the next case, and I invite Dr. Kiran to introduce the case.
Thank you very much, and good evening to all of you. Systemic envenomation from the snake bite in pregnancy can be a huge challenge for the management, especially in a resource-poor setting. It is a very rare and uncommon emergency in pregnancy, and especially in North India. So probably in my more than 25 years in GTB hospital, this is the first case that we have encountered of snake bite in pregnancy, which has a successful maternal fetal outcome. So I will now request Dr. Priya Shikha Modi, who is a senior resident, to present the case, and Dr. Natasha Tyagi, who is our assistant professor, and she was also actively involved as a part of the multidisciplinary team, which was responsible for the successful outcome, to discuss the case. So over to you, Priya.
Thank you, ma'am. Good evening, everyone. I am presenting a tale of miraculous survival of 2 lives. A 26-year-old gravida 2 female at 30 weeks of pregnancy was brought to our casualty with complaint of snake bite on upper back, followed by itching, weakness, ghabrat, and vomiting mixed with blood. Patient was lying on her bed watching her mobile, felt extreme itching and found that it was a snake, and following which she was given neem leaves and paste of neem leaves and chili, and following which she had vomiting, and she was immediately brought to MMG Hospital, Ghaziabad, and where she received injection Evil and Dexa and referred to our hospital for further management. This is the video showing this snake. This is the snake which was found in her room. And this is the pic of the snake. On examination, patient was conscious but drowsy with poor GCS, maintaining her saturation, and all her vitals were normal. And there was no snake bite mark present on her back. Patient developed ptosis and power in all the 4 limbs were reduced. On per abdomen examination, uterine size correspond to her period of gestation, non-tense, non-tender with normal fetal heart. There was no evidence of leaking PV and bleeding PV, and all other examination was normal. Diagnosis at time of admission was 26 years
Achla, do you want it to be presented again?
No, ma'am, I think you can reach to the slide. We had all.
Yeah, no
seen
need to
till that
present
place.
again. Just start
Yeah.
from where she stopped.
Acha, theek.
Yeah, we are extremely sorry. Actually, the LT internet.
Okay, ma'am, it happens.
At this one.
Yes,
Can't
ma'am.
be helped, you know.
Patient was lying down on her bed watching her mobile, then felt extreme itching and found that it was a snake, following which she received paste of chili and neem leaves, which induced vomiting in her. And patient was immediately brought to MMG hospital where she received injection Evil and Dexa and referred to our hospital for further management. This is the video showing the snake. This is the snake which was found in her room. This is the snake. Now, on examination, patient was conscious but drowsy with poor GCS of 7, maintaining her vitals and saturation, but there was no snake bite mark seen on the back. Patient had ptosis with power in all the 4 limbs was slightly reduced. Uterus was corresponding to period of gestation with non-tense, non-tender, and normal fetal heart. There was no evidence of leaking PV and bleeding PV, and rest examination was normal. Diagnosis at admission is 26-year-old female, unbooked, gravida 2, para 1, live 1, 30 weeks period of gestation with snake bite with neurological manifestation. After 4 hours of bite, patient was given anti-snake venom with neostigmine, atropine, and other symptomatic management. Despite all this treatment, patient went into impending respiratory failure, apnea, and was intubated. Post-intubation, patient had high-grade fever with tachycardia for which she received broad-spectrum antibiotic. Injection dexamethasone coverage was given for fetal lung maturation. On day 2, patient remained intubated with improving GCS, but there was significant rise in TLC level. Trial of extubation was done on day 3, but patient could not maintain her saturation, so was re-intubated by 3 p.m. There were fall in hemoglobin level and rise in INR level. So patient received 1 unit whole blood and 4 unit FFP. Now, as patient developed coagulopathy, there was persistent mild ptosis. So a repeat dose of anti-snake venom was given on day 3. On day 4, patient showed overall improvement. So patient was extubated in evening. And on day 6, patient was shifted out of the ICU in a stable condition after neurological, respiratory, and hematological improvement. And USG biometry was done along with NST. All was normal. On day 8, patient was discharged in a good condition, but she could not follow in our hospital as it became COVID-only hospital. She followed up in the nearby government hospital in Ghaziabad and had a full-term normal vaginal delivery of healthy, beautiful female baby of 2.5 kg on 1st November. So this is the happy ending of a tale of miraculous survival of mother and daughter duo. Thank you. Now, Dr. Natasha will cover the discussion part. Thank you.
Thank you, Priya. Coming on to the magnitude of the problem, the global incidence of snake envenomation is quite high, ranging from 4 to 18 lakhs per year, highest being in the region of the Asia Pacific, as can be seen from this figure. India leads this region with a figure of 81,000, followed by Sri Lanka and Brazil. Now, the incidence of snake envenomation is quite low in women and being rarer still in pregnancy, only quoted in terms of case reports. Few reports have shown the incidence of snake envenomation in pregnancy to be 1% out of the total cases. Since it was just the first case in last 30 years and it had a turbulent course with good maternal and fetal outcome, we decided to present this case. Now, learning about the taxonomy is important because the different families of snakes have different systemic envenomations which help us to identify and thus treat them. The Elapidae variety includes the cobra and the crate, and the Viperidae variety includes the Western Russell's viper. Now, the envenoming manifestations can be local, which include fang mark at the bite site, pain and swelling or blistering. Among the systemic manifestations, there are neurological, cardiovascular, bleeding, generalized rhabdomyolysis, kidney injury, and pituitary insufficiency. The neurological manifestations include bilateral ptosis, external ophthalmoplegia, and descending paralysis. Now, the cobra and crate both can have neurological manifestations, but the difference between them is that cobra will have local signs of envenomation also, whereas the crate will not. So, as it happened in our patient, there were signs of respiratory and neurological paralysis, but no sign of the local bite mark. Therefore, it was most probably a common crate. The management should be interdisciplinary and shared jointly between the obstetric and the toxicology specialist. First of all, first aid treatment should be given at the site of snake bite, followed by transport to the hospital. This is followed by rapid clinical assessment and resuscitation, followed by detailed clinical assessment, investigations, and antivenom treatment. The do's of the first aid treatment include pressure bandage immobilization and pressure pad immobilization. The don'ts include not to kill or catch the snake, not to use traditional therapy, not using incision suction rubbing at the bite site, not to inject the ASV locally, and never to use tight arterial tourniquets. The rapid clinical assessment includes history taking, followed by complete management of the airway, breathing, circulation, and disability. The detailed clinical examination includes taking of vitals, examination of the bite site, looking for signs of internal and external bleeding, a complete CNS examination, followed by a per abdomen examination in case of the pregnant female, and to rule out any vaginal bleeding by local examination. In all, we have to look for signs of maternal coagulopathy, non-reassuring fetal status, and preterm labor. The investigations include the arterial blood gas analysis, a bedside 20-minute whole blood clotting test, routine blood and urine investigations, a bedside ECG, chest X-ray, and specialized investigations when indicated. For the management in pregnancy, we have to first identify any signs of anaphylaxis or any signs of clinically significant envenomation. If any of these are present, we have to give the standard management of airway, breathing, and circulation, followed by antivenom and any expert management of the manifestation. Now, if the gestational age is viable and there is evidence of fetal distress or placental abruption, adequate obstetric management has to be done, followed by emergent delivery if needed. If not, then only perinatal follow-up has to be done. Now, regarding the anti-snake venom, there is a dilemma as to whether to give or not to give in pregnancy. Since antivenom has a high molecular weight of 50,000 kilodaltons, it is unlikely to cross the placenta, and there have been no studies regarding its risk in pregnancy. As regards the snake venom placental transfer, it is unclear, with indirect evidence indicating the same. So the recommendation says that the pregnant snake bite victims should receive antivenom, as would be indicated in a non-pregnant patient, because the risk of withholding the treatment likely outweighs the risk of antivenom administration. Now, the indications of giving antivenom are local swelling involving more than half of the bitten limb, enlarged tender lymph node draining the bite area, or any other sign of systemic envenomation. Indications to repeat include abnormal whole blood clotting test 6 hours after the first dose. If the patient continues to bleed briskly, we have to repeat it in 1 hour, or if there are other deteriorating cardiovascular or neurological signs. The maternal complications include obstetric hemorrhage, onset of preterm labor, DIC, hypotension, shock and anemia. Fetal effects include tachycardia, prematurity, neonatal jaundice, anemia, and sepsis. The discharge advice should be a telephonic surveillance of 1 week where possible, which should include a daily fetal movement count, warning the patient about late serum sickness-like reactions, and enforcing rehabilitation exercises of the bitten limb. A follow-up of the patient should be done every 2 weeks for routine monitoring and ultrasounds. The Langley RL did a literature review which summarized the worldwide snakebite experience in pregnancy for over a period of 40 years. It had 4% maternal mortality with 20% fetal loss. Another summary of modern case series of envenomations had only 0% maternal mortality with 8% fetal loss. So as and when good advent of medical management is there and better and highly purified FAB antivenom is available, the maternal mortality as well as the fetal loss has decreased. To conclude, since it is a rare event of potential morbidity, if there is early presentation diagnosis and availability of resuscitative measures, including anti-snake venom, precious life can be saved. This was a mother-daughter duo which was followed up at 3.5 months post-delivery and were in perfectly healthy state. On a lighter note, maybe even God wants to give some extra protection to the pregnant woman, because there is a myth in northern India which says that a snake goes blind if it bites a pregnant woman. Thank you. Now I hand over the mic.
Yeah, thank you, Natasha, and thank you, Priya, for the wonderful presentation. I'm sorry for the glitch that we had no internet connection. Now I invite the third, Rachna, Dr. Rachna, to introduce the third case.
Good evening, everybody. Anshuja, Varna, please share the screen. So our case is that of gestational gigantomastia. This is a case of incapacitating enlargement of breast, though benign but very rare, and it leads to a lot of myriad of physical symptoms, which is a challenge to deal in pregnancy, along with social and emotional hazards. So such a case would be presented by our senior resident, Dr. Vanna, and discussed by Associate Professor, Dr. Anshuja. Over to Vanna.
Good evening, everyone. So today we are presenting a rare and interesting case in obstetrics, pregnancy with breast agony, a double whammy. So our patient, 27 years, gravida 4, para 1, live 1, abortion 2, came to antenatal OPD at 28 weeks for antenatal checkup with abnormal increase in size of bilateral breasts, which started during the first trimester of pregnancy. The patient complained of breast pain and backache, and gradually she also developed breathing difficulty. The patient had self-visited the surgery OPD in 3rd month when a left breast biopsy was done. In obstetric history, the patient had a cesarean section 5 years back at term in view of preeclampsia. In the postpartum period, the patient had developed a left breast abscess which had to be surgically drained. However, the patient did not have an excessive enlargement of the breast. The general physical and systemic examination was normal. The pre-pregnancy weight of the patient was 60 kg, which made her BMI as 21.5 kg per meter square. And at 34 weeks, her weight was 72 kg, which made the BMI as 25.8. On obstetric examination, there was a single intrauterine live fetus corresponding to 28 weeks in cephalic presentation. On breast examination, both the breasts were grossly enlarged. However, there was no redness or ulceration. On the left breast, on the upper outer quadrant, there was a scar of the abscess drainage, which was done during the previous pregnancy. And on the left breast, on the inner quadrant, there was a biopsy scar, which was done during the 3rd month of this pregnancy. However, there was no loss of nipple sensation. So the breast measurements were taken in 3 parameters. The first was the circumference, which was taken from the axilla till the xiphi-sternum. This was 56 centimeter on the right side and 58 centimeter on the left side when the patient first visited us at 28 weeks. The second parameter was axilla to nipple, which was 27 centimeter on the right side and 28 centimeter on the left side. And the third parameter was nipple to midline, which was 26 centimeter on both the sides. So the Regnol's classification classifies the degree of breast ptosis. According to this classification, our patient had 3rd degree ptosis. On investigations, the routine complete blood count, liver function and kidney function test and serum electrolyte were within the normal limit. For the hormonal profile, serum prolactin and progesterone were done, which was normal. Prolactin was also repeated in the postnatal period, which was still normal. For the infectious causes, CRP and ESR was done. ESR was only slightly raised and CRP was within the normal limit. To rule out the autoimmune causes, rheumatoid factor, anti-TPO and ANA was done, which all were normal. And to rule out the association with Wilson disease, serum copper was done, which was also normal. So the ultrasound was done, which suggested grossly enlarged breast with heteroequic ecotexture and abundant fibrogranular tissue. There was also evidence of soft tissue thickening with edema and inflammatory changes, and there were also bilateral axillary lymphadenopathy. The MRI was done during the 3rd month of pregnancy. The Birard score was 0. The diffuse skin thickening over the left breast. Bilateral breast showed dense fibroglandular breast parenchyma with asymmetrically increased glandular parenchyma in outer upper quadrant of the left breast. And there were also multiple less than 1 centimeter axillary lymph nodes. The core needle biopsy done during the 3rd month of pregnancy of the left breast suggested mild chronic perivascular inflammation in underlying dermis. However, there was no granuloma or malignancy. So a provisional diagnosis of 27 years, gravida 4, para 1, live 1, abortion 2 at 28 weeks with previous cesarean section with bilateral gestational gigantomastia of unknown etiology was made. The patient, when visited us for the first time at 28 weeks, had to be admitted because of extreme discomfort. The patient was put on conservative management. She was given regular upper back physiotherapy. Breast support were given to her. Innovative ideas in form of homemade slings were given to her. So here in this picture, we can see that a homemade sling with dupatta was made and she was very comfortable with it. However, gradually both the breasts increased from 34B to 52D brazier size, and patient also developed bilateral axillary swellings. Regular maternal and fetal surveillance was done and FGR was gradually detected. The patient had excruciating pain, and so cesarean section had to be done at 34 plus 5 weeks in view of extreme maternal discomfort. She delivered a healthy baby of 1.8 kg. In the postpartum period, the patient could not breastfeed due to excessive breast size and shoulder and back pain, and consequently there was failure of lactation. So here in the chart, we can see that there was initially 28 weeks, the circumference was 56 centimeter. It increased to 61 centimeter, 34 weeks. And in the postpartum period, gradually decreased. And finally, in the 5th postpartum period, it's 40 centimeter. Similarly, in the left side, initially it was 58 centimeter, increased to 62 centimeter at 34 weeks, and decreased to 40 centimeter at 5 months postpartum. The axillary swelling on the right side completely dissolved. However, on the left side, it still persists with a measurement of 7 centimeter. So this table also denotes the same decrease in the size of the breast on the right side. And in this table, it shows the decrease in the breast size on the left side. So in this picture, we can see that there is the initial presentation of the patient with hypertrophied breast at 28 weeks. And then at the 34 weeks, along with the hypertrophied breast, she also have axillary swellings bilateral. So at 3rd week of postpartum, there was a regression in the breast size and also decrease in the axillary swellings. And there is significant reduction in the breast and complete regression of the right axillary swelling at 12 weeks postpartum. Thank you so much. Now I hand over to Dr. Anushita.
Thank you, Vandana. We diagnosed this with a working diagnosis of gestational gigantomastia of unknown origin. We actually started doing a round of the literature, and we found that this is a very debilitating condition, which was first reported in 1648 by Palmeth, and has an incidence of 1 in 28,000 to 1 in a lakh, and less than 100 cases have been reported in literature. It has been found to be more common in Caucasians and multiparous women, especially after the first normal pregnancy, and it usually starts in the first trimester, but can start in 2nd as well as 3rd trimester also. So now, how do we define gigantomastia? It could be massive enlargement of breast in a non-obese women in whom weight bearing itself is uncomfortable and stretching of overlying skin causes ulceration, or excessive breast tissue that contributes to more than 3% of the total body weight, or more than 1.5 kg per breast. And these measurements, they have been deduced from the post-mastectomy specimens. Now, there are different symptoms that women can present with, ranging from physical to psychological. Our patient had, breast pain. There was unrelenting pain in her shoulders, back, and neck, despite giving her regular analgesic therapies and physiotherapies. She developed a poor posture. She had breathing difficulty, and there was a gross breast asymmetry. Though you can have redness, itchiness, infection, ulceration, abscess, bleeding, hemorrhage, and loss of nipple sensation also. But not to underestimate, there are a lot of psychological problems that these women can face and they can lead to a lot of social stigma, especially with depression, social phobia, anxiety, and body image problems. Now, the etiology of this rare condition is unknown and is still debatable. The proposed theories are the exaggeration of physiological hyperplastic phenomenon of pregnancy driven by oversensitivity or overproduction of the hormones, especially progesterone. There can be association with autoimmune diseases like Sjogren's syndromes or rheumatoid arthritis. Drug induced, especially with penicillamine, has been reported in literature, and there is one case which has been reported after die-in therapy that was given for 6 months. Now, there are a lot of differential diagnoses that we could find in the literature, ranging from infectious mastitis to juvenile breast hypertrophy to fibroadenoma, Phyllodes tumor, non-Hodgkin's lymphoma, and lymphoblastic lymphoma, and finally inflammatory carcinoma of breast also. So that is why we concentrated on working up and the patient, exclusively, and we could rule out all these differential diagnoses in our patient. Now, coming to the treatment, because it's a rare condition, so the treatment is not standardized yet. It's a case-by-case approach. Conservative, medical therapy, surgical, everything is available. The conservative measures include proper brazier support, but for our patient, the braziers were not giving her a proper support, so we had to, advise her on making these home-based slings with these dupattas. She was given analgesia in the form of paracetamol, which had to be on and off supplemented by tramadol. Skin hygiene and adequate nutrition has to be given, and bromocriptine in the literature seems to be the mainstay of treatment because hyperprolactinemia has been reported in a lot of patients. It's an ergot derivative and dopamine D2 receptor agonist, but FGR is an isolated side effect. And since in our patient, the prolactin levels were absolutely normal and the FGR was consequently detected, so we wanted to withhold this treatment from our patient. And surgical interventions have been most successfully resolved this problem. They can range from simple mastectomy or reduction mammoplasty to bilateral mastectomy with reconstruction. And both these approaches, they have their own ifs and buts. But bilateral mastectomy with reconstruction should only be taken in women who are not desirous of future pregnancies. So now, what does the report card say about gestational gigantomastia, and what does the evidence on literature has? There are a number of cases reported, but only 3 out of these 100 patients, they have, tried spontaneous conservative measures, and they have found that conservative measures are a good bit if tried, if individualized, where you can actually, the patients got a total relief of their breast problems. The last 2 cases have been reported in 2021. So now, what is the take-home message? It's a psychologically and a physically debilitating disease of still unknown etiology. Appropriate workup with all the differentials in mind have to be kept. The management should be individualized between conservative, medical, and surgical interventions, depending upon what the etiology is, how your patient behaves, and what is she ready to accept. Wait and watch policy can be a realistic approach under constant supervision and homemade innovations. That is what we tried in our patients, and we were really successful in doing that. Regular follow-up with the obstetrician should be there. But the foremost and the most important thing that we have to, take care of these patients is the tender, loving care that should be there in BD, TDS, whatever doses we can. So tender, loving care is the best thing that, helps these patients to realize, accept their own body images and accept the condition they have. So size of the breast is always debatable. And never say that you have seen everything. Thank you.
Thank you, Anshuja and Vandana, for the interesting presentation. And I'll ask the judges, we have fourth presentation, which is, we'll shorten it if you want. Radhika can sum up it in 3 to 5 minutes, if time allows, because there was some problem with the internet.
Tell Radhika to make it 5 minutes. Huh?
Radhika, so we have a presentation from Radhika on Chaya. This is GTV data, and just cover it in 5 minutes. Thank you.
Sure, I'll make it very brief. So very good afternoon to all. The idea of our presentation today on this topic is basically to highlight that sometimes I think are my slides visible?
Yet not, ma'am. आ जाएंगे.
Yeah. So the idea is basically to share our experience of finding a very simple solution to a problem that we found during the course of our the slides haven't come yet all? They've come?
ma'am.
Okay, fine.
नहीं है.
अब आ गया?
नहीं.
Your screen is not there, Radhika.
Unshare and share again. Okay. Yes.
Is it okay now?
Yeah.
Yes.
Okay. Okay, great. So the idea was to just share our experience of having found a simple solution to a problem during the course of the clinical practice. So Chaya, as we know, is centromin, which was introduced in India as early as 1967. This is a brief of the use of the contraceptives through the NFHS data over the past 6 years. Condom is the most preferred one, followed by the female sterilization. The pills have remained constant at around 3%. Now, centromin, like I said, was introduced with a lot of fanfare as a non-steroidal birth control pill in 1967. It was developed by CDRI, approved by the drug controller in 1990. Saheli came in 91. 2016, Chaya was introduced in the National Family Welfare Program. So it's been quite a long time. And the most important part was it was advertised saying that there was no significant side effects except for delayed menses in about 8% of the healthy volunteers. However, what we found was, in the CSIR database, because it's very difficult to really come to know what percentage of women are actually on centromin. So it says that more than 8 lakh women are on Saheli, more than 2 lakh women are on Chaya, and minuscule of about 2,000 or 3,000 women in 2017, 18, and 18, 19 in Delhi. What about our own hospital? Very low percentage when we compare it with other forms of contraceptives that are in use. So we decided to really work on this and understand the reason. And this was a prospective observational study, and it was possible because of an ongoing ICMR contraceptive registry. And this is the registry focuses on PPIUCD and centromin. And we found that centromin, the number of women using them is very low, and we wanted to know the reasons. And the observation of this was from the OPD as well as in the ward, meaning the postpartum and the postpartum women. And the study period 2019 to 22. And after having obtained the ethics clearance and after counseling of the women, the usual steps for prescribing the contraceptives, the women who used decided to use centromin and consented to follow up of 12 months were observed. So average age was 26 years. Majority were primies, followed by the second gravidas. Most belong to the upper and lower strata of the socioeconomic strata. And what is important to be noted here is majority were in the postpartum period, followed by the interval, and then the post-abortal patients post-abortion. And majority of these women who were recruited for centromin had not used any form of contraceptive. However, of the 18% majority, they reflected the national statistics that I projected earlier. Most were on condoms. And then our data we assessed, and what we found, we started in September 19. Mind you, it was a pandemic year, 20 to 21. The number who were recruited was only 65. And then there was a jump start to about 325 from August 21 to December 21. And this was possible because we undertook a root cause analysis at the end of July 21 to understand the reasons why this was happening. And what the findings were amazing, and this is the fishbone analysis of what we did. And we found there were 4 P's which really affected the utilization of this contraceptive. Most important was the medical professionals And the reason was when we found the prescription itself was very low. And when we tried to find out from the professionals, the gynecologists in our department, the senior as well as the residents, everybody felt that they were aware of centromin, but it had not come to the pen. Number one, and there was also the concern saying that maybe there is not enough evidence to start prescribing masks to the people. And number three, they still thought that they all felt that it is important that they should work on it, and some of them didn't even know that it was in the 2016 basket of care, and hence the paramedical workers were not well informed. There were also the population, the women that we were working on had myths and habits. They thought that they would not conceive. They thought they behavior pattern regarding reproduction, they would not conceive within 2 years. Things like that. We are very used to hearing that. Women who had family support accepted family planning very easily. Very important factor about Chaya, the policies. ASHA workers are supposed to have Chaya and their kits. We found that majority of these women did not have, and thereby the continuation of supply was not given to them. Incentivization of the contraceptives like the ligation as well as copper T is not available for Chaya and the oral contraceptive pills, and this greatly affected the use, because we also found that the ASHA workers were important focal point for the women to be convinced of using a drug. IEC thereby is lacking from the direction of government. Regular supply is extremely important, and when we used, because this root cause analysis was also done not only with the paramedical and the medical staff, we also involved the stakeholders, that is the women who are using it. And one of the important points that came forth was lack of ready availability of the drug, and this is what made the women, consider they found it difficult to use it. So we thought the easiest is to rectify this, and we undertook the PDSA cycle 1, and we thought we will address these two later on. So this is the plan to study act cycle. So we wanted to improve the use of Chayam at the level of the stakeholders. We started providing them from 3 months onwards, immediate postpartum. It is important to understand today that as per the Government of India guidelines, Chaya can be used immediate postpartum, and it doesn't fit into any of the WHO criteria. It doesn't figure there at all. So we need to follow the Ministry of Health guidelines, so it can be started immediate postpartum. And like everybody else, I was also not very convinced of the immediate use. So we gave it to the ladies, and we told them we'll give them a call back after 14 days to confirm that everything is well and they can start immediately after we give them the phone call. And this resulted in a good usage. There was increase in the number of clients, and not only that, there was an increase in the awareness amongst the women and also amongst the community. So we were very happy to receive this success, and we decided to work on the other strategies which were already highlighted in the earlier slide, and to undertake further PDSA cycles. So without going into too many details, now we have about 100 women who are on follow-up. 153 are still yet to be followed up. The phone numbers changed, the women migrated, and we are still trying to, getting in touch with them. There was one failure rate, and this lady underwent MTP after that. The shift over to other contraceptives were basically copper T, condom, and natural methods, and this was because of the non-availability of the drugs, especially they were motivated by the ASHA workers. And about 76 of these women did not start, and the reason was they misplaced the pills that we had given them. Family did not allow, and they postponed it as they were busy with the baby. An important thing I just wanted to highlight about the side effects, we found that it is very well tolerated. The major side effects were initially within the first 6 weeks, and these were abdominal pain, weight gain, gastritis, and so on, which were easily managed with simple counseling. The menstrual irregularity was found in about 9% in the initial 6 weeks, and this was, much better at the end of 3 months. So this is a literature review. A lot of studies have now come in, but they are small sample size. I have only highlighted the ones with the large sample size. And here they basically have addressed the side effects, because that was a major concern in the initial phases when it got released. And mind you, 50% of these studies were by the HLL company, which had come out with Saheli in the market. So there is a huge bias and a conflict of interest there. But the good thing is the number of side effects were few, and the discontinuation rate in one of the studies was 31.5%. And in our study, we have put a query here because, like I said, about 153 yet to be followed, but as of now, it is about 5%. So there were very few studies which actually talked about the low utilization of centromin. And we just wanted to share this interesting experience. So the take home point, pregnancy associated events are important. And these are the times when the women can be, they're there in the hospital, and that is an opportunity for us to involve them in the shared decision making. Ready availability of contraceptives is very important to give the women the independence and privacy to use it. Does it also apply to PPICD? The answer is no, because many of these women, they feel that the cooperative was introduced at the time when they were so vulnerable, and that is why the removal rates have been also found to be very high. The dissatisfaction rates have been quite a few in PPICD, and hence shared decision making is extremely important. Today, for us doctors, it is important to realize that there is reasonable evidence for the safety of its use. However, long-term studies are yet to be there in the field. So I think as a spacing method, it is certainly a reasonable option. More IEC activities to create awareness are very important. Incentivization has to be reconsidered by the Ministry of Health. ASHA workers have to be, more sensitized towards the Chaya tablet. So with that, I thank you for your patient hearing.
Thank you, Radhika. And now platform is for honorable judges.
Thank you, Amita ma'am, and wonderful, wonderful presentations, all four of them as expected, especially the wonderful data presented at the end. I would now request our judges to please take up questions which they have. I'm sure as interesting the cases were, the questions must also be very interesting. Dr. Anjali Dabral, Dr. Uma Vaidyanathan, and Dr. Chandra Mansukhani. Floor is yours.
All the cases were really very well presented and managed. And regarding the first case, like Madam has said, the initial assessment should have been the best. I doubt they had taken a biopsy. Otherwise, in a 51-year-old lady with a complete family, they wouldn't have left the ovaries behind, which later proved to have malignancy. And you have stressed the fact that ovarian malignancy in the ovary is not in the FIGO staging for us in CS cervix. Your case was really wonderfully managed, and they were lucky they came to your center. The second case was terrible. I mean, imagine sleeping and getting a snake bite. Unlike North India, usually it's either cobra or crate, and like you kept on emphasizing that there was no mark, so it was a crate. But how was the blood pressure of this lady?
The blood pressure of the lady was normal because there is no cardiovascular manifestation of crate. It belongs to the elapidae variety. So the blood pressure was normal. There was only some tachycardia associated because of the fever she had, and later on she developed a slight component of sepsis because the TLC also started increasing. So that can be a late manifestation of any type of snake bite. So the BP was normal, but there was certain amount of tachycardia.
Okay, because it's written that you're usually due to crate bite, blood pressure can rise. So anyway.
Crate generally causes neurological manifestations with no local sites.
Because the parasympathetic activity decreases, no? And of course,
ideally,
that was also an amazing case.
Dr. Dabral, ideally there would have been the low BP because it was an anaphylactic shock. So with tachycardia, the BP would have gone down. But it was she was maintaining. That is a very good.
Crate bite is specifically written that BP does rise.
Okay.
If there is any onset of anaphylactic reaction, then the blood pressure will rise, but not always there will be the anaphylactic reaction. It can be associated with the anti-snake venom also.
And the third case, though it appears simple, was really rare and difficult to manage. And of course, I kept wondering why you were doing prolactin levels. Then you said that it rises in such cases. But maybe it's due to the effect of estrogen. I don't know. But how did you support the breasts? I mean, I'm a bit curious.
Ma'am, actually, the braziers were not enough for her breasts to be supported because they became so heavy. So we kind of tried multiple things, but finally we came to the, we were just enlightened kind of, we tried to make a sling for her with her own dupatta. so that could support her breast, and we tied that sling on behind her neck as well as behind her back. So that is
and also supporting her on the table, which was kept on the bed. That was a great idea. The table took all the weight. And we've shown it in that picture also. Table took the weight along with that homemade sling in our ward itself.
So you kept her admitted throughout?
Yes, ma'am. We tried to discharge her, but she then again comes back crying because of that weight, which she couldn't manage at home. So she used to go home and come back also. So it was both psychological and family support also she had. So intermittently she was admitted. Pardon,
What
ma'am?
gravida second, I think, na?
Yes,
Was she
ma'am.
a second
Gravida.
gravida?
She was a second gravida, and she had no such problems in her first pregnancy.
Thank you, Dr.
Amazing.
Anjali.
And the prolactin was also normal. The last thing that Chaya is actually very good, and we give it immediately postpartum also. So it is really a wonder if it was available better. Thanks a lot.
Yeah, so thank you very much, Dr. Amita and Dr. Kiran Guleria, to you and your team. They have presented all the very interesting cases and very nicely, and all cases were crisp, very interesting and very rare cases. So ma'am is Dr. Amita is my teacher, and her team is also excellent. So I would like to ask one question regarding the case 1. The first surgery, exactly when it was done, and what was the exact indication? Whether she was diagnosed CS cervix at the time of first surgery?
No, ma'am, she wasn't.
Doctor?
It was done in a private hospital in UP, and it was done for vaginal bleeding, like for AUB, somebody did a surgery
So
and they
actually-
written TH without a biopsy, even without
Okay.
examination, they just had written TH.
So we don't know what was the exact staging at that in the first surgery.
Yes, ma'am. There was
So
no
that is why-
staging. So it was at least 1/3 because the tumor size was around 6 centimeters. And later on, 1 month later, the PET CT revealed some parametrial involvement and some vaginal wall nodule also. So it must be an locally advanced CS cervix, but it was at least 1/3 because the tumor size was 6 centimeters.
Yeah, so it was very interesting, and one should be very, very careful in these type of the cases, really preventable. If we would have been, that first doctor would have been known the staging, the surgery would have planned in a very good center, or the third level 3 center would have been planned. So, and the case 3, Dr. Natasha and Dr. Kiran, the case was very interesting. I have seen so many cases, the snake bite, but not with the pregnancy. So it was really interesting. It was really interesting. It's a new thing. And sitting in the metro, you just cannot imagine, in the capital of the India, you just cannot imagine the pregnant lady is coming with a snake bite, and you managed very nicely. And at least the baby is also saved and mother was saved. So that was very interesting.
And I want to share one interesting fact that video was taken by the husband. Immediately
great.
after that lady grabbed
very
cautious away, that he quickly took that video and then brought it.
So he was very courageous man. At that time, he was not, I mean, in the stress, he could manage to take the video. That is a very good, commendable thing.
Exactly.
Great.
A caring husband would get the patient to hospital rather than taking video.
But I think that was his presence of mind that he did
Yeah.
that immediately.
This is also an important part of this presentation, that it is generally encouraged, if the snake is dead, then they can bring the snake or they can take pictures of the snake. It helps in early identification of the snake.
Yeah,
Like
absolutely.
in our country, we have multivalent snake venom, but sometimes in certain countries, single monovalent snake venom is available, which will act only against a specific type of snake. So for that, it will be important.
Yeah, very good. And there is one question regarding the case 3, Dr. Vandana, I would like to ask. You have done the prolactin in your case and it was normal, and whether there is any evidence in the literature, if we try the bromocriptine in this, we would have tried this bromocriptine in this case and we would have helped her out, whether there is anything in the literature.
Usually the bromocriptine, all the literature showed it was more useful when the prolactin levels were higher, and but in the normal range, there's no study which showed that the bromocriptine was
But
useful.
No, but usually the prolactin level is always high in the pregnancy, always.
Ma'am,
So
it's
I'm
higher than in
surprised
the
how
pregnancy. It's on
during
the high.
pregnancy, normal pregnancy, the prolactin level is always high.
Yes, ma'am.
And especially in the third trimester.
Yes, ma'am.
So I'm surprised whether it was normal. And suppose it was normal and there was this problem. So whether there was any role of the MRI in the literature. Suppose we would have done the MRI of the pituitary to know the any prolactinoma. Though in the prolactinoma also the prolactin level can be normal. So
yes, ma'am. Actually, yeah, the prolactin levels were normal. Usually we do not see this ways in pregnancy. But when we followed up this patient, she had FGR also. So that was the main reason that we wanted to withhold bromocriptine from her. And she was, and when we counseled the patient, she was not willing to take any medication. She said, just said that I want conservative treatment, whatever it is. She was not ready to take that risk.
Yeah, okay. So I would like to ask one more question, whether this surgery is possible during pregnancy also in these type of the condition?
Ma'am, usually whatever the literature says, all the surgeries, wherever these have been done, they have been done post pregnancy, or if there was a sudden massive hemorrhage in the pregnancy itself, then these were attempted. But elective surgeries were all done postpartum.
Okay, suppose the condition persists then only.
Yes, ma'am.
Because in your patient, the condition improved, she improved.
Yes. The final brazier size that the patient is wearing was 42 days. No, now, ma'am, it is 38D now. The last
38D.
Yes. Now it is come
so
to
almost normal or
normal.
nahi? But initially it was 34D, 34B or
yes,
D.
she was wearing 34B, but then she is much satisfied now that her appearance has become almost normal. So she is very happy. She doesn't want to pursue any kind of treatment.
She could not feed her baby.
No.
Okay.
The breast was so heavy, she thought that the baby would get smothered. So she didn't try, and consequently there was failure of lactation.
Okay. Thank you. Thank you very much. And in the last, I would rather congratulate Dr. Radhika for her very nice presentation. And actually, because if the Chaya is so easily available and it's so safe in all the stages of the patient, female life, but still it is not on our pen and we are not using right and left. Rather, we would have used and female would be very compliant and very comfortable. So once again, thank you very much, Dr. Amita and Dr. Kiran for your team nicely presented all the cases and very interesting cases. Thank you.
Thank you for your comments. Thank you.
Thank you, ma'am.
Dr.
Yeah.
Uma, you have any question? Yeah.
Amazing cases. It's been an afternoon absolutely well spent, without any doubt. I had just one question for the gigantomastia case. That was the indication for delivering the baby related to the fetal growth restriction or related to maternal discomfort?
No,
That's my query.
Yeah, the indication was extreme maternal discomfort. Her breast size became so heavy that, and the physiotherapy was not working, the analgesia was not working. So she was not able to take it anymore. We somehow pulled it from 28 up till almost 35 weeks.
Almost 35 weeks, yes.
Yeah. So she was absolutely done with it. She was crying left, right, and center that, I want to end this pregnancy.
Okay, so this
it can, and further prolongation can lead to stretching of nerves. And
yes.
she can land up in fifth intercostal nerve fallacy.
Okay.
So we have to judiciously take the decision when to terminate.
Okay.
And regarding surgery also, there are few indications like massive hemorrhage, failure of bromocriptine, pharmacological therapies first, and failure of pharmacological therapy, we can go ahead with surgery. And if we do surgery in pregnancy, the breast will again enlarge because it is a sensitivity of hormones in pregnancy which leads to enlargement. So it is surgery is preferred postpartum after failure of pharmacotherapy, which is bromocriptine. So I think that would have answered the query.
Thank you. Thank you. Thank you all.
So thank you. I thank the honorable judges, AOGD team, and our speakers for the today's presentations.
Yeah,
And,
I can see Dr. Sunita Mittal also there, Amita.
Yes.
Dr. Mittal. Dr. Sunita Mittal.
Yeah, I mean,
Yes,
Dr.
we have commented in the chat box as well.
Yeah, Dr. Sunita, are you with us?
Hello.
I saw her comment.
I mean, I've got her unmuted.
Yeah. Dr. Sunita?
Yes, hello.
Yeah, hello, good evening.
Good evening. Very well
Your
done.
comments, ma'am?
All three cases. First, of course, I couldn't hear completely because I joined when just the discussion was telling. But the other two cases which I've heard are wonderful, wonderful, really good. And even review of Chaya and the study is good. So well done. Very well done.
Thank you so much.
Thank you so
Dr.
much.
Renu, yeah, thank you, thank you. Dr. Renu?
Dr. Renu?
I actually wanted to ask a question. Amita, what is the mechanism of sepsis in snake bite?
Ma'am, as snakes have the snake's habitat is in the jungles or like such places, and especially if they ingest their prey, it is given in the literature. Sometimes the prey passes feces while being ingested. So that is the mechanism, and because of the aseptic conditions, because of the conditions, because of their habitat, that is another, because they can inject sepsis during the time of their bite. And secondly, because the patient was in the ICU, so secondary infection might have also set in, but but the TLC came out to be normal towards the end.
But I mean, is it a usual thing to have sepsis with snake bite?
Yes, ma'am, it can happen. It is reported in literature.
Because they don't live in a sterile environment, no?
But it is coming out of the body, like monkey bite, dog bite. Do people have sepsis?
Yeah, sepsis can set up in any of the poisonous bite.
Okay, and another thing
If
about
you see the limbs which are apart from being swollen, and there is always there's a component of sepsis also, and you need to give them antibiotics.
Anyway, so very interesting cases, like always from GTB, you hear something new and interesting. I just wanted to say about the first case also that, I mean, why did you think of taking the ovary out when it was buried and there was no uptake on the bed?
Ma'am,
lucky that you got it out.
Yeah. So I know we were planning to complete the surgery. We were in any ways, because she had already undergone a hysterectomy and we are opening her up. The ovaries are buried under dense adhesions at the vault. And since we could not find any vault, growth or anything, we thought that maybe it was the ovaries which had prolapsed and got stuck at the vault. Maybe they had taken uptake. We thought it improper, and one side, the left ovary, was slightly enlarged also, which came out later to be positive. So once it was this, and also we went back to the first PET CT when it was just done 2 months post surgery, when the initial surgery was done, when the hysterectomy was done, the PET CT which was done 2 months post surgery showed a left adnexal uptake. That was like 1.5 years back. So both the things combined made us suspect that maybe it was ovaries which were stuck at the vault, and there were actually very dense adhesions which we had to separate and then take out those ovaries. We opened up the vault, but there was no growth visible.
Because normally you don't think of ovarian involvement in cervix.
Yeah.
You're talking about ovarian conservation in cervical cancer.
Yes, ma'am. So that is why we were so surprised. This was actually a rarest. It has all the rare things: ovarian metastasis, cutaneous metastasis, a synchronous thyroid malignancy. I mean, everything rare was there in this lady.
Good. Great show, Dr. Amita. Great show, team
Thank you,
GTB.
and thank you for logging from the very beginning. Dr. Ranjita, please. Unmute, please.
Yeah, so really very, and I don't know from where you get these cases. Right? So the snake bite, this is for the first time. We got to know so much about it. See, I think one thing, just want to ask, the one who had a cesarean, I think this was the second case, right?
Second had a normal delivery, that was snake bite.
Was expedited by a cesarean.
Which case you are talking of?
Talking about this, the one who was on the ventilator.
No, she had
no,
normal.
Not that one. The other one, breast one.
Yes.
Gigantomastia. So why did she have a cesarean?
Ma'am, she was a previous cesarean, and
okay, all right.
Yes,
Okay,
so, and she was just 34 weeks, and
that's okay. That's all right. Thank you very much. Very well presented and really interesting case. Thank you. Well done, UCMS.
Thank you.
Thank you, Amita. As always, like everybody, I will echo everybody said that you always get very interesting cases. But I think the cherry on the top was Radhika's presentation. I think I urge everyone, that things which we have our Indian Saheli Centromin, which is so good. Why are we not using it? Why are we not creating data so that WHO will take notice that this should be included? It is, I think, our fault. We should be, using it more often, create data, and do something about it. We are all there from all institutes, and we have so many patients. And if we tell our patients, they would take it also. I think it's a very good idea to do more studies like what Radhika and all of us in all institutes should do it, and a collective data to give it in an international journal, and so that it is also included in the list of the contraceptions.
Actually, I think, the biggest hesitation is that most of the studies are drug company sponsored. And actually, we do not, lots of times, you don't believe the data. And there is so much of responsibility on the prescribing doctor. If you see the hormonal contraceptive otherwise, the other hormonal contraceptives, how much, research they have gone, has gone into them. And with this medicine so confined, and majority of the studies sponsored by the
That's what I'm saying.
company.
Why don't we do? I mean, it is.
That's what I'm saying. Unless we do for proper research, come out with the evidence, and then we start asking to write. And what we do here, you see, even after this meeting, people are happy to recommend writing. How can we start writing? On the basis of what studies?
That's what
No,
we
I
have
would
to
like
let
to
me
add to, what
Let me answer that query. If you want me to get involved in a research, or see, I'll be very happy that if I prescribe, this goes on record, and all the data should be collected of that patient.
So you have the kind of registry.
I would like to
Yeah, that is what is happening. In fact, that is the kind of registry that is a project, the ICMR project that I am working on, that is ongoing in our department, is a registry on the use of Centromin. And I truly appreciate your thought, Dr. Ranjana. I would actually share similar, I had similar reservations, and that was the reason for putting forth this concept. And thankfully, ICMR accepted it. So, because of the pandemic, the sample size was, we could not arrive at that. Now we've got an extension for 1 more year. So probably after 1 year, we might be able to give a better, because 390 sample is our study. None of the other studies have anything more than 150. So I think, and then following this, a systematic review, something to really substantiate. I truly agree with you. But as of now, it seems to be quite safe as a spacing method. At least for 1 or 2 years, most of these studies have addressed for at least 12 months. And to that extent, it seems to be safe enough.
Yeah,
but
Radhika,
yes, we need more objective evidence. I truly do understand, and I agree with you. Yes.
But
So
we don't have the dearth of numbers. So if we really want to do a research first and then collect the evidence and then recommend, we will be very quick in collecting the data, right? Numbers. We'll have a huge number, right?
Yeah, and the interesting part was it's not now confined only to India. Now Centromin has been approved for use in Peru and in one of the European countries too. So they have gone through our data. The CDRI has been quite transparent in their data, but the phase 3 trials onwards, there was some kind of a loss of interest in that direction. So we should certainly work in that direction and pick up those threads and provide more robust evidence. Yes.
Yeah, but I agree with Dr. Ranjana that we need much more data, because as a gynecologist, I'm not convinced myself. And obviously, I cannot promote it and prescribe till I'm convinced.
Yeah, it's a point taken. Absolutely. We certainly do need, but because we've been working on it since the past 3 years. So as a spacing method, I am kind of convinced, but I would certainly agree with you. We need more data.
Let us create more data.
Absolutely. Yes.
It's our drug. We need to create it.
Yeah. Okay.
So can I add something to what
Yeah.
Achla just said? Very, very important point. She's raised that it is our drug and we have to promote it. It was put up in the World Health Assembly data in 1994, Sencromine. And a Government of India sent a representative and I was sent as an expert there. And when we were discussing, WHO was very pro to include it into WHO list of essential drugs. But unfortunately, we could not get enough data from even CDRI. There was no toxicological data. Nothing was there, so nothing could be achieved. Subsequently, we were trying with Ministry of Health. So finally, it got a placement in the National Family Welfare Program also. But however, as Radhika also pointed out, even ASHAs don't have it. Doctors are not aware of it. So we ourselves are not using it enough, despite being a very, very safe contraceptive. So what all these experts have been discussing, Ranjana, Achla, and Kiran, and of course, Radhika is putting up, and Amita, I think all of you need to take it up at a great level. It's a great drug, unfortunately, and it is extensively being used in Nepal and Bhutan, purchased from India. That's the beauty of it. So I think we need to work on more on this, definitely. And Radhika has done a good job by collecting some statistics. We did try to do some research studies, but again, small work in a corner doesn't get so much of weightage internationally, right? So very good.
Thank you.
I think all of you need to take up Sencromine in a big way. Right?
I think Dr. Anjali Dabral is saying that they are using it extensively. So
but we need to collect data, we're using it, but we're not collecting data. That is the irony of it, We need data so that we can.
I think people are using immediately postpartum.
Yeah, we are using it, but that's what I'm saying, that unless we have data, just hearsay doesn't really help anyone.
No, because of shortage of time, I did not highlight this. The women who promised to take this immediate postpartum, despite a phone call, did not take it. They started taking it after about 1.5 months, 2 months, 3 months, variously. So, but since it was available with them, they started taking it. That was the point.
Right.
Chalo, it has been a nice discussion.
Thank you.
And I think we must thank the Conference International. Without glitches, we are able to do all our meetings, and AMCure, who have been providing this platform for the monthly meetings without asking for anything, any promotion from their side. So we must thank them also.
Yeah, everybody knows Shivam. He's so now known to everyone because he's holding every meeting. Thank you, AOGD, for giving us the platform. Thank you.
Thank you very much.
Thank you.
Goodbye.